Hit the record. My bad. We were just rolling. All right. So this is afferent coming in. We wind up the capillaries. We exit as efferent. So I remember exit efferent, evade efferent. And then what we're going to do is create a positive pressure and push into Bowman's capsule. This is Bowman's capsule, the structure around here. When we do that, that's the filtrate. It's going to enter into PCT. We're going to do different things with it. Then thin descending loop of Henle, thick ascending loop of Henle, DCT, and eventually into the collecting duct as urine for the most part. Okay. As we're going through here, we're going to learn or see that we're talking about secretion and reabsorption. So you need to know in every section what happens and who's moving, what ion is moving. All right. I'm going to switch to the camera for a second because actually, let me see what's on the next slide. Okay. Let's just talk about the next two slides and then we'll talk about it on the board. Cortical nephrons, these are the shorter guys. So a majority are like that. And then there's the juxtamedullary nephrons. These are the real long ones. And these are important for concentrating urine. That's where we pull out a lot of water, is in those guys. Okay. The renal corpuscle, like we said, glomerulus, Bowman's. What's lining it? Fenestrated epithelium. Fenestrated glomerular epithelium. So if you remember, that was important for filtration. It allows things to pass. What is going to pass through here? Ions, glucose, not proteins, okay? Is going to pass through there and not cells, all right? Once we go in, we'll start reabsorbing things or we'll dump more things into it. That's our filtrate. So whenever we talk about filtration, is passing through this membrane. All right, so I'm gonna switch to the camera for a second because it's kind of weird to explain this using the images, in my opinion. I think it's better if we just draw. There we go. And then we'll zoom in. Before crowbars, crows used to have to drink at home. Come on, that's quality. All right. This is glomerulus. This marker is junk. It's like faded. Oh, this one's nice. I found a nice one. It marks a lot. So it marks a lot. All right. Glomerulus. This is afferent. This is efferent. So we don't confuse it. Bowman's capsule has two layers technically. So what happened was he used to be shaped like this. And he secreted VEGF, vascular endothelial growth factor. This used to be just a regular old guy. When he secreted that hormone this way, this guy grew that way. And that's why he wound up. And when he grew, he did what's called invagination. So he pushed this structure in. So by pushing this structure in, what happens is we end up with, I drew that kind of, so let's make it better, okay? There we go. So we took that one layer and we pushed it back, and it's kind of sitting on itself, if you will. So this inner one here, this guy, that's the parietal layer. Nope, visceral. Listen. Visceral. This outer one here is the parietal. All right. Yeah, that is wrong. Today is not my day. My brain. I woke up at like 4 o'clock in the morning. I don't know why. Just wide awake. I'm so annoyed. Just wide awake. It was like hot, thirsty. It was just like wide awake. So I've been up since 4 o'clock in the morning, and that is not normal for me. All right. So bear with me. So we created this double layer. The one that is touching the organ is visceral. The one that's outer, parietal, just like we saw before. What we'll see is we've created filtrate. How are we creating filtrate? We're creating a pressure that is greater here than what is in here. That's a hydrostatic pressure, like we learned already. What we're going to learn, though, is because there's fluid in here, there's an opposing hydrostatic pressure. So now we're fighting each other. Then we have protein in here. That's osmotic or oncotic pressure. So we have another pressure pulling back. So what we need to do is create a greater pressure in here than your normal blood vessels. So what do? We dilate the afferent, or we constrict the efferent. By doing so, think about it like if you took a hose. This is the hose connected to your house. And you pinch this guy. The pressure in the beginning of the hose goes up. That's increasing GFR. The amount we're filtrating is increased. Well, it's the same thing what if I could just like expand my hose here? Same thing, more water could go through, and I keep this guy kind of tight, more pressure here, right? Increasing GFR. And then if I choke it, well, the pressure in here becomes a trickle. So what happens? Decreased GFR. So you always need to pay attention to what part of the vessel they're talking about, afferent or efferent, and then if we're constricting or expanding. Is it letting more pressure into here, or creating back pressure into here, or reducing the pressure into here? Okay? As we go through here, we'll see PCT. When you guys look at him in lab, he's cuboidal. And he has little microvilli in here to increase absorption, so he looks hazy. So we're cutting this tube, and then we're looking down the tube. You guys looked at this in AMP1 if you took AMP1 with us. This is where you learned the simple squamous that's lining here. Very thin layer. That's what you guys learned your simple squamous. Then we have thin descending. He's simple squamous. Okay? Then we have thick ascending. He's cuboidal. Then we go into DCT. He is just cuboidal. That is horrible, cuboidal. And then collecting duct. We're not going to worry about him really, because when you guys look at these in lab, if we're talking about the pyramid of the kidney, what you're going to be looking at is a nephron like this. So when you look up here, you're going to see this structure and this structure, these three. When you look down here, you catch these two and here, and you can't differentiate them. Technically, if you see simple squamous, it's him most likely, but what we're going to learn, there's actually vessels looping around all of this. So we can reabsorb, we can drop stuff in. So the vessels could be simple squamous too. This guy's cuboidal, this guy's cuboidal. You can't tell who's who. All right. So parietal layer, simple squamous. Visceral layer, also simple squamous, but they've specialized into what are called podocytes. So what's happened is we have the parietal layer on that outer simple squamous, clear as day. The inner simple squamous have grown feet. Podo is feet. So they're cells with feet. And what it's doing, it's fusing with the capillary membrane, with a basement membrane between the two. And between these feet, these little gaps, that's where we're passing the ions, glucose, okay? We're passing it through there to create the filtrate. If this is damaged, that's when you start to see protein in the urine. That's why protein is never appropriate in the urine. Because if you're seeing it, that means podocyte's been damaged. That's specifically what it means. There's even a disease in children. It's like an autoimmune disease. For some reason, the podocytes just suddenly efface. And the kids start peeing out protein like crazy. And the parents will bring them in and they have like puffy eyes because they're losing that osmotic pressure. There's edema. And their ankles will be edema. And then if it's like a little boy or something, they'll talk about like when they're standing up to urinate, it's very foamy. It's all the protein in there. And usually we'll admit them to the hospital. We'll put them on temporary dialysis and they'll go back to normal, usually, but not always. Sometimes they actually end up needing a kidney transplant. So here, this is what they're showing. Afferent coming in, efferent going out. Those are the podocytes. That's the parietal layer. The gap is the capsular space, the glomerulocapsular space. This would be filled with filtrate. Here's a close-up of the podocytes. So those little gaps there, that's where we are allowing things to pass through. They're so tight that the large structure of the protein cannot make it through. PCT has microvilli. So because he has microvilli, he has a lot of surface area for reabsorption. We see a lot of reabsorption here. Where are we reabsorbing? Into the bloodstream. So like that efferent will come around and start looping around the nephron before it goes back to renal vein. That's where it would be terminally headed. Okay. So here you're going to see a lot of reabsorption. We can do secretion here, so we can pump things out, but really the big focus here, reabsorption. How are we doing that? Transmembrane proteins are pulling things back in. Thin loop of Henle allows for water to freely pass. He's thin, simple squamous. Thick, cuboidal, columnar cells, things don't pass unless we have pumps. So we will pump stuff out from here typically. And then DCT, no microvilli, so he's bigger for secretion than reabsorption because he doesn't have all those fingers to touch everything. So the collecting ducts, really at that point, it's primarily urine. You can reabsorb some water from there, but for us, we're really saying at this point it's waste. We're just getting rid of it. And where does it dump into? The minor calyces, which then dumps into major calyces. Okay? Then we head out of kidney into ureter. Cuboidal, no microvilli, and like I said, we can do some reabsorption of water, tweaking salt, but that's really about it. So this is a good image because it shows all the different layers in one, like what we just ran through with the different areas. So you need to know what cell structure is there. And then, like I said, we're going to have to go through what's absorbed, secreted, filtered, all of that for each area. All right, so glomerulus, afferent arteriole coming in, then we have that little tuft of capillaries, and then efferent exiting. The purpose of glomerulus is filtration. This is the only time we use the word filtration. You don't use filtration anywhere else. Filtration, glomerulus. That is it. Why are we able to do this? Because we create a higher pressure in that glomerulus than what's inside the nephron, inside that glomerular capsule space. Okay, we can create higher pressure there. Peritubular capillaries, so this is that efferent when he loops around and he starts wrapping around the rest of the tubule and allows for reabsorption or secretion. I think vasa recta been moved from your notes. I forget. I feel like vasa recta has been removed from your notes. But if it hasn't, we're going to go through it anyways. So vasa recta is... Someone opened the door and left. Rude. Vasa recta is the long vessel that comes down around loop of Henle. And the purpose there is to concentrate the urine. So we'll yank out solute on the ascending loop, and then as it loops around, it now has a lot of osmolarity in it, and it can pull water out of the thin descending loop. Okay? So it's referred to as countercurrent pressure or flow. So what we're going to do is we have filtrate going like this. And then we have a vessel, the efferent, the peritubular capillaries, specifically vasa recta, going the opposite way. So what we do is, when we come through here, we pump out solute like crazy. Specifically, the drug that works here is Lasix. Lasix, or loop diuretics, that's their name. Loop diuretics work on the loop of Henle. And what we do is we punch out a bunch of solute. So now I have all this solute here. This is simple squamous. So what happens? Water leaches out here. And so as we're pulling the water out of here, there's not a lot of water down here. It's pretty like high osmolarity. There's a lot of like solute because we haven't pulled it out yet. And then there's a lot of solute here in the vessel, but not a lot of water because we haven't pulled it out here. So when you look at the tip of the pyramid, the medulla, the very tip of it, they call it the salty region, or the very salty area, because this is way down there. This is really salty. This is really salty. Okay? I feel like last semester my students told me it's kind of been pulled. So yeah, right here, that's what we're talking about. Because we're yanking out the solute going by, it's very salty in the vessel. And then because we're yanking out the water as it's coming down, it's very salty in the nephron. So that's that countercurrent when we mention that. So only time we talk about filtration, glomerulus. Reabsorption and secretion, we'll talk about it through the rest of the nephron. So filtration membrane, what is made up from? The fenestrated endothelium of the capillaries, so simple squamous. The basement membrane, and then the visceral membrane of Bowman's capsule, aka podocytes. That's it. So the problem with like UTIs, if someone has a UTI, it goes up the urethra, into the bladder, into the ureter, into major calyces, minor calyces, and now we're here. And the bacteria climbs and climbs and climbs and goes, and now when we're here, it's 2 cells Two simple squamous cells in a basement membrane before we're in here. That's a problem. That's when you get that septic patient. So when patients have pyelonephritis, which is an infection of the kidney, they get admitted and we start giving IV antibiotics because that's it. They can go septic at any point. So we have to give them IV antibiotics, and that's why all UTIs should be treated. A UTI should never go untreated because that's where you're going to end up. Looked at this image. Okay. So what the fenestrations, no cells pass through it. This statement's wrong. I leave it in here in case a question comes along, but logically it doesn't make sense. So they're saying the basement membrane has a negative charge, and because of that negative charge, it repels the proteins from coming through. It's not true. It's the gap between the podocytes, because going back to that childhood disease that pops up, the podocytes come off, nothing happens to the basement membrane. It's still stuck there, and proteins start flooding out. And then as soon as it goes back, the proteins stop. Okay? It's fine. Learn it. The book says it that way or whatever. We'll go with it. So here they're showing that's the endothelium of the capillary. That's the visceral layer of Bowman's capsule, podocytes, and then there's basement membrane between the two. So we mentioned the kidneys. The kidneys get a big chunk of our blood supply with every stroke of the heart. I think we said, a quarter of cardiac output goes to it every minute. That's a lot. So your kidneys nonstop work. They're saying your entire blood volume about 60 times a day. That's high efficiency. So that's why when patients go on dialysis, it's kind of miserable. They have to go 3 times a week usually, and they will tell you they will lose 10 to 15 pounds after dialysis. That's how much builds up in their bloodstream because their kidneys aren't functioning. So they'll walk in, they'll walk out 2 to 3 hours later, 10 to 15 pounds lighter. And I'm over here, been working since January and lost a whopping 6. Come on. My wife and I, we've been watching My 600-Pound Life, and we're just like, that dude just lost 90 pounds in 1 month? How? It's just wild. Wild. But then we also did watch him sit down and eat, I think it was 12 corn dogs, plus an entire tray of tater tots. Wow. Anywho, so filtrate, that's now what has gone through the glomerulus into the capsular space, into the nephron. No proteins, no cells. Okay? No proteins, no cells. And even though we filter our blood 60 times a day, of the total filtrate, of what makes it into the nephron, less than 1% is urine, becomes urine and waste. So why does that happen? Because what we're going to see is we reabsorb stuff like crazy. We pull it out of there using transmembrane proteins and aquaporins to allow water to come back in. We pull it back out and put it back into our blood. We don't want to lose it. Okay? So glomerular filtration, that's how we're making filtrate. Then we do tubular reabsorption. 100% of glucose and amino acids, if you're eating a normal diet, will be reabsorbed. Okay? If you're on keto, you can see some amino acids. Amino acids are small enough to make it in there and make it out. But true protein structures, we should never ever see. Right? We should never ever see glucose unless you are a diabetic. If you have glucose in your urine, you are a diabetic. No ifs, ands, or buts. Unless you take a medication that causes it, right? But as a regular person, glucose in the urine, that's just indicative of diabetes. Okay? So that's reabsorption. We're pulling it back into our bloodstream. Secretion is where we put stuff into the nephron on top of the filtrate. So maybe maybe only so much makes it out, then we stack in there and we can put more. So you can actually have a clearance rate. You can clear more from your bloodstream than your GFR, your glomerular filtration rate. Meaning, I'm going to make up fake numbers here. Let's say you filter out 10 milligrams of medication, penicillin, enters with GFR, with the filtrate. As that filtrate is going along in the nephron, at different points, like the DCT, for example, your transmembrane proteins can add in like 5 more milligrams. So when you look at the urine, someone could have 15 milligrams of penicillin in there because of that tubular secretion. So we can see an increase of secretion or an increase in urine of a certain like metabolite or material than actual GFR because of secretion, okay? So as we go through here, like I said, you have to know what's being reabsorbed specifically or what is being secreted specifically as we go through. So GFR is measured as a sign of kidney function. So whenever you guys go get like blood work, stuff like that, they're measuring GFR. And we're going off of that to kind of see how your kidneys are doing. But it should be here, they say about 125 mils per minute or the equivalent of 45 gallons a day. We reabsorb, like I said, we reabsorb a bunch of it, of that filtrate, and then create our urine from there. And they said, less than 1%. As we age, we lose nephrons. GFR decreases. So when GFR decreases, especially when you start getting into like meds, you can't dose the patient the same as like a healthy individual. Or if they have end-stage renal disease, you can't dose them the same because the clearance rate of the drug, they won't clear it the same. It'll accumulate in their system. So they have to adjust it accordingly. But yeah, keeping your kidneys healthy is important. Hydration, hydration, hydration. So I'll take a hydration break. Not assaulting it with things like aspirin. Aspirin damages your kidneys. All right, so how do we create the filtrate? We rely on hydrostatic pressure. So like normal capillaries, they say it's like 30 millimeters of mercury. In the glomerulus, it's like 50. The reason being, we can dilate that afferent arteriole, we can open up the floodgates, and then we can constrict the efferent. We can tighten it down. By doing so, the glomerulus is seeing that extra pressure. We create that extra high pressure. Okay? So typically, afferent is dilated, the efferent is constricted. We can regulate it, we can change it. So here's afferent, there's efferent, there's glomerulus. The dark blue represents glomerular hydrostatic pressure. And we're saying it's worth 55 millimeters of mercury. 55 millimeters is pushing out. The green represents osmotic or oncotic pressure. That's like the albumin and the solute that isn't making it out in here. Really the albumin. It's pulling back into the blood vessel. So right now we technically have 25 pushing out. 25 millimeters of mercury pushing out or as filtrate. But the problem is you have fluid in here. That fluid, also because of secretion, is increased. So what does it do? It's pushing back. Because it's pushing back, we now have capsular hydrostatic pressure. So now we're pushing out 25, but 15 is pushing back at us. We negate the 15 with the 25 because it's greater, and we end up with 10 millimeters of mercury pushing out. So what I like to do when I'm like calculating these, just so I don't lose my mind, I put next to anything that is going out of the glomerulus a positive. If it is stopping it from going out or pulling it back in, it gets a negative. So when you do that, now I'm taking 55 minus 30 minus 15, and what I get is my net filtration value. Right? So we covered this with like blood vessels. We talked about it. All right. So this is what we've been mentioning here. We can alter the pressure, that hydrostatic pressure, depending on what we do with the afferent and efferent. So if I dilate afferent, GFR goes up. If I constrict afferent, GFR goes down. If I dilate efferent, GFR goes down. Okay? Dilate, afferent, GFR up, more in. Constrict efferent, in this situation, GFR is up. Reverse, GFR decreases. So lisinopril, that specific drug, that's our number one line therapy for high blood pressure. And then we also give it to diabetic patients. We give a super low dose. So when you do that, you increase GFR. So if someone has high blood pressure and I increase GFR, we filter the blood more efficiently. We make more filtrate. We make more urine. I decrease the volume load inside their vessels, decreasing blood pressure. For diabetics, having more blood flow through here helps protect the kidneys. So lisinopril, like we throw lisinopril at anyone and everyone, except for African Americans. It does not work on them. The reason, well, it can, but it's not first line. The reason being, the African Americans in the genetics, the vessel hardens. And so when you give them lisinopril, it won't dilate. And so it doesn't work on them usually. You get, providers will try it, but usually we go with like HCTZ, hydrochlorothiazide, the water pill. And we'll talk about that guy. He inhibits the aquaporins, and so you just pee out water, straight water, right? Osmotic pressure, like we learned, that's really the big player, is albumin. He's pulling water back into the vessel. He's not going into the nephron, so he can't take water with him. So this is the math we went through. Y'all can go through it if you need to. Same image. Filtrate, it's equivalent to plasma. And remember, cells can't make it out, proteins can't make it out. Even platelets are too big to make it through there. All right? Everything is too large to pass through the podocytes. So here they're showing well, they're not showing everything, but here there should be another layer here. We should have the layer for the simple cells of the glomerulus. Then we should have basement membrane, and then we have podocytes, and there's the slits. So these structures are all too big to pass through. All right, so PCT, here now we're going to start to see we reabsorb things. We're pulling it out of the filtrate because we don't want to lose it from our bodies, and we're putting it back into our bloodstream. Why? Because he has microvilli. So remember, he can touch more. So what's reabsorbed here? So whenever we're going through each of these sections, you need to know what's reabsorbed. So reabsorption, 100% glucose, always, unless you're a diabetic, 100% amino acids, unless you're on like a high protein diet. Then you can see that excess amino acid in your urine. We don't need it, we pee it out. The body will adjust whatever levels it needs as long as you're getting the appropriate amount in. If you get too much, it's going to get rid of it. Like, for example, do you take a multivitamin, your urine turns yellow. Why? It's too much. With our diet, our body doesn't need that extra. It's not doing anything for us. You're just peeing out your money. Okay? So same thing when people that are working out and they're just like, oh, I gotta have protein shake, protein shake, protein shake. Well, they're taking amino acids. It's excess. The body will get rid of it. And that's normal. Okay. They always joke about how when these people are on high protein diets and when they pass gas all the time and it's very foul. It's just too much. They can't even absorb it. And it's just going through their gut. So they're just wasting a lot of money. Also, I'd prefer to just take my protein as a nice steak. Let's be honest. All right. So we reabsorb water here. We have our potassium, magnesium, phosphorus, all phosphate, all of this, urea, uric acid, and sodium. So PCT is our big player for reabsorption. Why? Because he has microvilli. We'll see in the loop of Henle, we'll reabsorb sodium, potassium, chloride through transmembrane proteins. And then DCT, he's the fine tuner. He just tweaks it the last little bit, pulls in water, him and the collecting duct. That's really all their claim to fame is. So, threshold maximum. We'll use the board for this for a second. Share camera. All right. Let's say you secrete into your urine glucose, which we all do. There is a point that we can reabsorb up to, and I think your book says 180 milligrams per deciliter for glucose. I think that's our max. That's the threshold point. I could be wrong, but I believe so. But let's say you secrete 300. You'll reabsorb up to the 180, and then this will spill over. Everything above that dotted line will now be seen in the urine. You've exceeded what the transmembrane protein can pull back in. And the only reason we're seeing this huge spillover in a diabetic patient is because they don't have enough insulin to pull it into their cells. If you produce insulin, you're going to pull it into your cells. We shouldn't see the extra in the urine because you'll never go up this high. Doesn't matter what you eat. Eat a bowl of candy, won't matter. All right? So we should see, we should see 100% of glucose reabsorbed, and we should see 100% of amino acids. Amino acids, if you have too much, that's fine. If it appears in your urine, no big deal. Not a big deal. That spillover is when we reach transport maximum. Who's our transporter? Transmembrane proteins. You max them out because there's too much coming in, that's it. It's going to spill over into the urine. All right. Water follows solute. They're saying sodium, but it's solute. Water follows solute. Okay? So we'll see when we reabsorb, we'll pull water with it. Water will follow it. As long as it's simple squamous or even if it's cuboidal, it can kind of go through, right? With the transporters, there are three things we talk about here. Co-transporter just means two things are moving. You don't know if they're moving together or opposites. Co-transporter just means that transporter can carry two things through it. Antiporter means they move opposites. One goes in, one goes out. Symporter means they go together. Okay? So glucose and sodium are co-transporters. They're both being reabsorbed. That means glucose and sodium are symporters. Amino acid, sodium, symporters. They're co-transporters, they're symporters. They're both being reabsorbed. Sodium and hydrogen, antiporters. So if I have too much sodium in my blood and I start getting rid of sodium in my urine, I have to pull hydrogen in. If I have too little sodium in my blood and I pull the sodium back in, the hydrogen goes out. They can flip. Okay? Antiporters can flip. The sodium potassium chloride symporter, that's in loop of Henle. That's what Lasix inhibits. The second it inhibits it, that solute stays in your tubule, in the nephron, and through the DCT, through the collecting duct. Guess who follows him? Water. And that's why loop diuretics are like our strongest diuretics. You give it to someone and just water dumps out of their body. The problem with that is they develop low levels of all of these guys. All the ions tank because they're just peeing them out. Except for one thing, uric acid. Uric acid will go up in them so they can develop like gout symptoms, hyperuremia. That's the only thing you see elevated in them. Okay. Sodium, potassium, antiporter. So these are opposite. Sodium moves in, potassium moves out. So here it breaks down where they're at. This is what you need to know. Okay? So like in the PCT, sodium, glucose, sodium, amino acids, sodium, hydrogen. Know that if they're antiporters or symporters. So if I reabsorb sodium in the PCT, I'm pulling in amino acids. Same thing with the loop and the antiporters in DCT and collecting duct. Leave that up for you for a second. Secretion, this is where we're getting rid of stuff. So when we have extra and it didn't make it out in the filtrate, we'll get rid of it. Or maybe it was too big, okay? Like penicillin, too big, so we'll secrete it. All right, so we have urea, creatinine, potassium, penicillin. We'll rely on this effect. Say someone has like a UTI and I want to treat them. Well, I can only give certain antibiotics. Part of the reason is what works on the organism. The other part is it has to come out in their urine. What if it's secreted like as in bile? Then it's useless. So knowing which drug to give on how it's secreted can be very important, or like where it's eliminated from the body. So like penicillin is used for syphilis, for example. We must. Okay? All right. So nephron, like we mentioned, filtration, reabsorption, secretion. What controls this? Hormones. Hormones are going to control this. So like when the body sees sodium as low, it's going to secrete a hormone to say, bring back in the sodium. We need to keep it. So what are we on? Let's stop there. That's a good stopping point. We'll keep it a little short today because that gives me, let me just peek at our schedule again. Today's 13th. Yeah, we can finish it next class. I'm pretty confident in that. And even if we don't, we'll move on to on March 20th. We'll go through the last little bit and we'll finish electrolytes, and that'll give us a free day on March 25th to have like a review. Okay? All right. Any questions? If not, enjoy your weekend, and I will see y'all on Monday. Bye.